Thank you so much for the invitation to speak today. I'm going to ask a question. Is there a best surgical treatment for primary congenital glaucoma? And I'm going to try and give a long-term perspective on this question. I'm Peng Kaur. I'm speaking from Moorfields Eye Hospital and the UCL Institute of Ophthalmology in London. The management and treatment of congenital glaucoma obviously has many facets. But today I'm just going to really talk about the surgical treatment and probably exclude cyclodestruction. There are, of course, other issues associated with treating glaucoma, but I'm not going to cover those today. Again, just a brief mention of medical treatment, because actually from the UK-wide study, it clearly is a mainstay of treatment in addition to surgery. But again, I won't be going into detail on this. So let's go straight into surgery, goniotomy. Now, of course, there's goniotomy and there's goniotomy. There can be different knives used. Viscoelastics are used. In the case of our practice here, for most of the cases, interestingly, viscoelastic was not used, and it was just done with a tapered knife. And of course, different lenses can be used. Goniotomy is the reference standard treatment for primary congenital glaucoma. It has advantages in that it preserves the conjunctiva. In the UK, it's possible with 90% of cases with epidermal removed, and it can be performed in both eyes simultaneously, and this is pretty well the only operation we do like that. The instrumentation is relatively simple, and of course you can do 360 if you use viscoelastic, but you do need familiarity with the angle of surgery, and that is very operator dependent. And of course, poorer responses for those with severe corneal edema present at birth, very large eyes, and of course older age groups, and of course this must be taken into account when deciding what operation to do. On the left here, you'll see a video showing stripping of the cornea, and you can see a very opaque looking cornea very rapidly becomes visible, even with a huge split down the center. And you can easily see how now goniotomy can be done, and this is true in about more than 90% of cases in the United Kingdom. On the right, you'll see a goniotomy being done without viscoelastic, and you can see my assistant is holding the eye, sweep to the left and then sweep to the right. You'll see the angle dropping back, a classical PCG angle, and that's the end of this particular procedure. And those few seconds of goniotomy in this particular patient have lasted more than 25 years. Now, if you look at the long-term prognosis, and this is long-term, this is a 30-year follow-up of the initial cases done at Moorfields. And this is the picture on the left shows a gentleman I still look after, and his goniotomy was done 60 plus years ago, and his pressure is still 10 to 12. And you'll see here that the survival curve is pretty good, considering that the survival curve here is 30 years for one or two goniotomies. Now, there are many different techniques, and here we see trabeculotomy, done more traditionally, although it was originally described by Redmond Smith using suture. A 120-degree right and left probe can be done initially then with 360-degree Prolene, and then more recently with the eye track cannula, which you see there on the right, with a flashing light, which makes it a lot easier and makes it less likely that you'll be sending the cannula posteriorly down underneath the retina. And this can be done actually both ab externo and interno, which we've done here at Moorfields. It's useful, particularly if the cornea is too opaque. The downside of being ab externo is it violates the conjunctiva. And so I changed the Moorfields technique doing this to infratemporal about more than 20 years ago, and this has been very advantageous if further surgery is required. We now, of course, use the 360 eye track illuminated fiber optic, but of course it's costly, and we prefer this to the Prolene suture, which is technically more challenging. Also, not forgetting that combined trabeculectomy using the probe plus trabeculectomy has reported very good results in many centers in India, and particularly that from Anil Mandal. And also the results from the 360 proline, again done in Atlanta, the more recent report, the largest report by Neustein and Beck, showing good results. This shows the results from the Neustein and Beck study, and you can see here the 360 proline trabeculotomy showing a superior result to 120 probe trabeculotomy or goniotomy in this particular series. And this is a good follow-up with about a 180-month follow-up here plus. If you superimpose the Moorfield goniotomy result from that, you'll see that they're actually relatively similar. And again, just to make the point that angle surgery done well, both externally or internally, can give you a very good result. And of course, the advantage of goniotomy is it doesn't violate the conjunctiva. The disadvantage is that if you want to do most of the angle, you're going to have to use viscoelastic, but that's not a very severe problem. Filtration surgery, including trabeculectomy, is a primary treatment in some centers, particularly where angle surgery equipment is not available or there's no experience. And Moorfields, we've always combined this with an anti-scarring treatment. Originally, beta radiation was used in the absence of 5FU or MSC, but more recently, mitomycin C has been used. Knowledge of an altered anatomy is vital, and obviously follow-up with bleb-related problems in some cases is important. There's a higher risk of hypotony and bleb-related complications unless appropriate techniques are used. And here you see the fundamental difference between how you apply mitomycin C as a broad area of treatment versus a non-broad area in the same patient. And the patient on the right has had the newer technique of the now well-established broad surface area treatment, the safer surgery treatment. And you can see that the relative incidence of bleb-related complications is hugely different if an appropriate technique is used. This shows the good results you can get in both primary and secondary glaucomas with anti-metabolite assisted surgery. And this is using the techniques of the Moorfield safer surgery system, including a large treatment area, carefully titrated flow, particularly in these large eyes which are susceptible to hypotony, and with very good long-term results and minimal bleb-related complications. Anti-scarring therapy has to be used, and this is the initial result showing the success rate in both primary and secondary glaucomas without beta radiation and subsequently with the use of beta radiation. Now, beta radiation is minimally used around the world because the probes are very old, they're historical, and they're more difficult to obtain and now require quite a long duration of treatment. But this is using more recently beta radiation in Africa, showing that mitomycin C versus beta radiation was more than 5 times more likely to give a pressure of a lower pressure off medication than mitomycin. And currently in production, there's a new radiance probe, which hopefully should take 30 seconds and will be revisited. Drainage tubes are better if they're poor prognosis eyes, and better if subsequent surgery, such as cataract surgery or graft surgery, is needed. The main short-term problem is hypotony, but various surgical interventions, such as microligation, infusion, and a blow valve have made a huge difference to this complication. It's minimal, and it Moorfields less than 2% of choroidals. There are many different implants, but here you see the audit results of our Basel versus Mortina. You can see the larger surface area implant has a much more successful outcome. And again, if you compare that to other smaller implants, such as the RMED, with a similar time scan, you can see that the larger surface area implant has a better outcome. So in conclusion, we've got improving methods for surgical treatment of primary congenital glaucoma, better risk stratification of patients. The choice of surgery is great, and with many newer techniques coming up, coexisting pathologies will alter decision, and further improvements are now possible with better preservation of vision in the long term. Thank you.